And so with that, what was your hope as people walked away from the session of that message that they took back home to their hospital, their research organization, or like you said, their advocacy group, the pharmaceutical company, thinking of all those different touch points and like you said, the different perspectives that were brought into this session from the payer viewpoint, from the research, clinical research standpoint, from the clinical care standpoint, what was your hope that they each took back to their home institutions?
I think my biggest hope for the field is that we remain collaborative. I've, like I said, 3 decades of experience in life sciences, Alzheimer's disease, towards the second half, but I've worked in other disease states that were absolutely not collaborative. They were dog eat dog, they were competitive, academics fought, pharma companies fought, organizations fought. I mean, honestly, sometimes we were spending more time fighting with each other than we were actually focusing on the patient. And that's a really special thing about the Alzheimer's community is, there's a very rare instance where you don't see people collaborating. A lot of that this has been a slog. It's been really hard. And we've needed to kind of pick each other up and we haven't had enough resources. And so there has been a ton of collaboration. And that's probably my biggest hope. And the takeaway I want people to walk away with from that conversation and any other that we have, which is as we grow, as we, sell more products, as we have more companies started, as there's more money in the field, let's do everything we can to keep the soul of what we are in Alzheimer's research and care, which is let's collaborate. Let's keep the patient and the science first and try to put everything else behind us.
Oh, so important. I think, one of the focus of patient-centered care right now, is really all over the place. And making sure also that the different stakeholders that have a role, whether it is the individuals developing, like you said, the cognitive tests, the people who are developing the pharmaceuticals, people who are, determining how the clinical trial should look, statistical power, et cetera, are making sure that it all, like you said, interconnects, and then that the outcomes, the therapies and the diagnostics that come out the other side are going to be covered by insurance, FDA approved, and useful for clinical. So thank you for helping to be a part of that critical conversation.
We used to have a little trick that we did on our team, our Alzheimer's team at Lilly, and that is when we started to have a debate or a discussion, someone on the team started as me, but then anybody would do it, would say, would a patient care about this conversation? Is it moving it forward for a patient? And would we be proud to have them listen to this conversation? And if the answer was yes, then we finished the debate. If the answer was no, then it was make a decision and move on. And I think it's a really good rule of thumb for us to do across organizations as well. If we're in some sort of debate or some sort of battle, to stop and say, is this going to move the field forward? Would a patient be proud? And if the answer is yes, okay, have the debate. Scientific debate is good, right? If the answer is no, make the decision and move on. And I just think it's good. It's a good way to check yourself.
Oh, I love that. That's a great benchmark. I'm going to remember that. Thank you. So looking at if we could take a little bit broader look at the conference as a whole,
Mhm.
there were a lot of amazing sessions, a lot of key things that happened at the conference. And one of those was the Alzheimer's Association releasing those first clinical practice guidelines from that organization on the use of blood-based biomarker tests. So if you could share for us, what do you think is the significance of this and how might it change the diagnostic process for specialists?
So how exciting is it that we actually have blood biomarkers now? I mean, 5 years ago, we just didn't think this was going to happen this fast, and here we have it. It's just amazing, and it really is transformative for research and for clinical practice. So super important and exciting that the Alzheimer's Association, obviously one of the leading voices from an advocacy perspective, put together those clinical guidelines because we know that doctors look to those trusted voices before they take action, before they change their um, activities in their own clinical practices. Interestingly, this was actually the second set of guidelines that were disclosed. The first set were from an organization called the CEO Initiative Against Alzheimer's Disease. And they actually were a little different in the way they did the guidelines. The CEO initiative basically started with use cases and then said, let's set the minimum specifications for the blood tests for each of these use cases. And then a paper was put out in Nature with Suzanne Schindler as the lead author that basically said, here's how blood tests can and should be used. They did not focus on specialty. And the reason for that is we do have people in this country that are in specialist deserts. They don't necessarily have access to a specialist, or maybe it's a very long wait for a specialist. And so that was more based on the qualities of the test specs, um, positive and negative predictive value for each use case. The association's guidelines really focused on these being blood tests that are used in specialty care. And so they had a real focus on this being something that's used there. There's good reason for that, but it does create a challenge when it comes to equitable access and when it comes to speed. So I think the important thing to note is we really won't move people through the patient flow faster if we don't get these blood tests into primary care. That's really where they need to happen. And the association isn't quite ready for that to happen yet. The CEO initiative was a little more ready for that, provided that the test met the appropriate specifications and the providers had the training that they needed. So, we'll work through this as a field. At the end of the day, we have to celebrate the scientific progress. But I know if I had had a test like this for my dad, it would have changed our entire experience with this disease.
Oh, that's such an impactful statement for you to make that. Yeah, I I feel that the importance of, like you said, health equity and access to care is so critical. And there's so many people who can't get into a specialist, or the period of time to get into the specialist, like you identified, is critical. And those, that concept of time saved and minutes count, once you're in that process of cognitive decline, acting early is so critically important. And if you lose, 2, 4, 6 months waiting to get into that specialist to get that diagnosis, that could be critical time lost. So yeah, I definitely hear what you're saying, and I hope that we see that we see it. There's a pathway to move it into PCP spaces.
I wish it was only 2 or 6 months. The average wait time in this country is over 9 months now.
Wow.
And sadly, if someone is a candidate for one of the new therapies, the data is very clear that it works better the earlier you use it.
Mhm.
So we need to work really hard as a field to get these workflows and these clinical practice guidelines and these diagnostic tools implemented in a real world setting so that people, wherever they live, are able to get access to the therapies if they choose and if they are a candidate for the therapy. We don't want that to be limited based on their zip code.
Yeah. Do you think that we will ever get to a future space? I guess it's just a speculation question where, like, you're recommended to get a colonoscopy at a certain age, or like you're recommended to get a prostate exam or something, where we will start to do cognitive testing for individuals as a baseline at a certain age, and possibly even biomarker testing at a certain age to, gather some of that information and maybe identify people earlier?
Yeah, so there's two steps in the diagnostic process, and you just hit them. The first is early detection of cognitive impairment, and the second is accurate diagnosis of pathology. That early detection of cognitive impairment should be happening today. The annual Medicare wellness visit actually requires that a cognitive assessment is done for all Medicare beneficiaries. So if you're 65 or over in the United States, you have a legislative right to have a cognitive assessment at your baseline. And it's really important to do it that way because your best measure is yourself and
Yeah.
change over time. Unfortunately, they are very, very rarely done in this country. Um, and even the acceptability of the doctor just kind of doing their own assessment is okay for the annual wellness visit. And, we all know that doesn't work with mild cognitive impairment, right? Doctors have 6 or 8 minutes with their patients. It's not accurate. So unfortunately, currently the US Preventative Services Task Force does not recommend cognitive assessments. You're able to do it. They don't not recommend them. They just don't recommend them. That's something that needs to change. It's an inconsistency in our own legislative policy between the annual wellness visit and the USPSTF. But, I would love to see it at age 50, right? I mean, why wouldn't we be thinking about our brains? I mean, I don't go into the doctor and not get my blood pressure taken, or
Right.
my cholesterol taken or my fasting blood glucose taken, and I don't have any diabetes in my family. But I do have dementia in my family. Why aren't they testing my brain starting at age 50 every year? Just so that I know that everything's okay. And, now with technology and digital cognitive assessments, we're actually able to do those in a very standardized, validated way with task shifting to lower cost resources in the health setting. So honestly, that could and should be happening today. Blood tests, which is your accurate diagnosis, that's a little bit different.
Mhm.
The blood tests as they stand today are only validated with their cutoffs for people that have cognitive impairment.
Yeah.
So the way this works is a blood test has a certain sensitivity and specificity, but their positive and negative predictive values are based on what population they're used in. So you can imagine, right? You're going to have a higher positive predictive value in, say, a memory center than you are in the general population. So the cutoffs and the interpretation is really matters. These PPVs and NPVs really matter. And so they're only validated and essentially approved or recommended for use with people with cognitive impairment. So in terms of kind of screening with a blood test, I think it's possible in our future. And I think certainly if the preclinical AD studies, Trailblazer 3 for Kisunla and AHEAD 345 for Leqembi, I think if they hit, then yeah, I think we might be having to talk about blood tests because now you're talking about I need to find amyloid in people who aren't cognitively impaired. But today, the blood tests are really just for use for people with cognitive impairment for whom they would like to have that pathological diagnosis.
Outstanding. Well, I hope we do see that growth and that preventative,
I think
early
it could be in the next
diagnostic.
5 years.
Oh,
Absolutely.
I really hope we get there. I'm a big believer in, in the preventative annual wellness checkups to try to gather some of that baseline information. Because having dementia in my own family, that process of realizing that when people go in and they take those tests, that everybody comes in at a different space, right? They're everybody's cognition and cognitive capabilities are different, and we're all coming in with different spaces. And so what are we measuring against? What's the threshold? Because there's the concept of change, and then there's a concept of a number that says this is the number that if you go below this, there's a problem. But it would be lovely to identify that there's changes happening before somebody hits that number.
Yeah, there's a standardized normative database that almost all the tests use today, which is based on your age and demographics and things like that. But really, your best indicator is yourself. And that's what I'd like to see happening. And hopefully, it'll happen soon.
Outstanding. Well, you mentioned the Leqembi, and I'd love to dig into that a little bit because there was a
Mhm.
session at the conference where the University of Washington's Memory and Brain Wellness Center study was shared by Dr. Michael Rosenblum on the Leqembi, and it highlighted that key trade-off of academic clinics offering more advanced infrastructure versus private clinics initiating treatment significantly faster and having equal safety. So given that the study's main takeaway is that sooner is better, how do you think this is going to shape patient choices and influence the future of care delivery?
It's so interesting when we compare our academic settings that have, to your point, lots of infrastructure, wonderful researchers, heavy NIH grants, but they also have different incentives for what they need to be doing, right? To further the institution's mission. That includes research, that includes grant writing, that includes publications. Those are all things that take up time. And it's just a different set of incentives. When you go to the other institutions, the non-academic, whether those be, private or not-for-profit, right? There's a lot of not-for-profit hospitals in the United States. Their incentive is around making sure that they can financially stay afloat. And what's interesting is today in this country, neurology is a losing specialty. Um, Neurologists don't do large, expensive um, interventions like cardiology or orthopedics. And as such, neurology is often a place where hospitals are watching close to see what's going on. So for those systems where those financial incentives are really important, volume and throughput matter. And they're running a business. I mean, healthcare is a business.
Mhm.
So you do see a lot quicker uptake. You see faster decision making. The cycle for governance and for decisions to be made are much quicker. Um, and then you see those systems m- adapting workflows very fast. Unfortunately, it's not the norm for people in the United States to be diagnosed at all with Alzheimer's disease. And it's certainly not the norm for them to be diagnosed early. And so it takes a full mindset, culture shift, workflow change. And workflow change is hard. And it's really hard in an academic institution where the disciplines are set up, sometimes independently, or like I said, they just have different incentives. So you asked about the question of patient choice. Um, I'm not sure that your average patient is going to know the difference between those two things. I do think your affluent, educated population that's out on Google, that wants to do these things, they can find the information. And I think those folks will move someplace where they have the opportunity to get the therapy if they want it. I have had several uh, friends call and say, we went to XYZ academic institution. We thought it was the best. They're telling us we have this really long wait. Where should we go? And I was like, well, try this institution. And sure enough, they were able to get that infusion earlier, and they know that early matters. So I do think for a subset of our population, a very, very small subset of the population in the US, people will potentially chase that. But I think for the most part, you're just gonna have kind of variable access because of different uptake, rates.
Well, it ties back, like you said, to that phrase again, equity and access, right? I think the more we can streamline things and make policies similar across institutions across the country, hopefully we can improve that access so that, people of privilege and who have the ability to be able to move or to be able to travel for care, that's not just isolated to that group, that population, that everyone can have access to that.
I don't think there's a disease state that I've ever worked in where kind of health seekers aren't the first users, right? I mean, and the
Yeah.
first patients. It just is normal. Our goal as a field should be for that to be as short a time period as possible before things even out. It's really important when you look at the impact. So today, the standard of care in the United States of America for Alzheimer's disease is an unpaid family caregiver.
Mhm.
We're one of the wealthiest nations in the world. And our standard of care for this disease that impacts millions of people in our country is an unpaid family caregiver. And so you can imagine this has generational impact as well. If people are having to leave the workforce to be a caregiver, or if they're, having to buy down assets in order to be able to get to Medicaid. And so we're going to see a really long tail of a lack of health equity if we're not careful. And we do know that people with lower social determinants of health are at higher risk. We know that communities of color are at higher risk. And so it's one of the reasons I went and got this public health degree, because I just think we need to be thinking about brain health like we do other public health topics. And we need to make sure that as fast as possible, we move out of this, affluent, privileged setting of the people who get the therapies to anyone who wants the therapy or would be a candidate for therapy being able to have access.
Yeah, outstanding. And so true. I mean, the other piece on that is that access point and the caregivers a lot of times right now are sandwich generation, right? They've
Yeah.
got young adult children who may be finishing high school, heading into early college, and then they're starting to care for an aging parent. And, the data on the impact and the increased risk for a person who is themselves a caregiver. I mean, I think that's the other thing, lifestyle factors being so important. And when you're in a caregiver role, especially if you're also still raising kiddos and still trying to work, is you're not sleeping as well and you're not exercising as much as you should be, and you're having more social isolation because you're in, you're spending more time caring as opposed to connecting with outside individuals, and each of those cascades together, which then increases the next generational risk. So yeah, I think it's so.
Absolutely. We know stress, lack of sleep. But here's another scenario for you. What about the 20-year-old kid who's caring for his grandmother
Yeah,
because she raised him?
right.
And now he's potentially having to alter his life course to care for the woman that cared for him. And so I just think these are things that are fixable.
Yeah,
And we as a society should say, let's get them fixed. These aren't things that we necessarily have to wait for science to fix. These are, I'm not going to say healthcare system transformation is easy. I'm telling you, it is not for the faint of heart, but it is an engineering solvable problem.
yeah,
And it's simpler with the exception of the way our billing codes work in this country, but it's easier than coming up with a new drug. So let's
absolutely.
fix it, right? Let's fix it. And then, of course, I'd be remiss if I didn't say the other benefit of early detection is people can be offered a clinical trial as part of their care plan. And today, we do not have enough clinical trial participants to adjudicate the full number of clinical trials that we have in our pipeline. And so that's the other reason that early detection is so important, and that we're making sure that anyone in any community has the same access to clinical trials as well.
Outstanding. I have another question for you. So, looking at that conference, and you guys talked about the past, present, and future of Alzheimer's disease. So, leaning into the future, what breakthrough do you think is going to have the greatest impact in the next 2 to 3 years on either Alzheimer's diagnostics or treatments?
Gosh, Marcy, there are so many breakthroughs coming at us. The innovation curve that we are on in this field is just, it's a hockey stick. I mean, it really is. We're just shooting up in terms of innovation. And it's hard to pick one thing. I would say, could I pick one from each category? Am I allowed to do that?
Absolutely.
Okay.
Absolutely.
So I think if we could get um, AI and big data and these digital health solutions adopted in clinical practice for early detection. And when I say adopted, that means you have to get all the pieces right, right? They've got to get into the Epic and Cerner EMRs. They have to be paid for. Um, but that just is first of all, you're collecting way more data and you're taking out variability from say raters and pencil and paper, and you can task shift to a lower cost resource, which is a really important thing in a health system. So I think if we could get those adopted where everyone, I'd love to say 50 and over, but at least if we said 60 or 65 and over, everybody in the Medicare population had that baseline cognitive assessment, I think it would have a dramatic impact on care and stigma. Because right now, the only people who get a test is when you're worried about them. But if
Mhm.
everybody, I mean, there's no stigma to getting your blood pressure taken because everybody gets it, right? So I think if we did that, that would have a dramatic impact on the field, and just in general, um, the way we think about our brain health. In terms of blood tests, I think if we were able to get those moved into a primary care setting in a way that they were standardized and you could compare results across blood tests, I would love to see that happen quickly. So, today, if you get an HbA1c taken, your numbers should be under 7, but you don't know which HbA1c assay was used or which test was used. They're all standardized. We've done that for PET scans with a measurement called scintilloids, but we're not there yet with blood tests. So I'd really love to get out of the argument of which blood test is better and get to the let's standardize these blood tests. So regardless of which blood test you get, you're able to look across them. I think that would be huge. And I think it'll allow it then to be more interpretable and be used in more frontline settings. And then the third thing, the thing that's going to blow the doors off is if these preclinical Alzheimer's trials hit. Unfortunately, A4 did not, which was the one that I ran. But I think we learned so much from that study that's have informed these next two studies that are rolling out right now. If those studies are positive and we can see 30% or more slowing in this disease, or potentially even stopping the onset of symptoms, that's going to be transformational. Because now, those other things have to happen, right? Now the early detection and the accurate diagnosis have to happen. So those are the three that I would be praying for.
Outstanding. Yeah, I think each one of those is remarkable and so important. And the one that really resonates to me the most, because they're all extremely valuable, but what you said with stigma is such a key point. When you think about when they say you need to get your colonoscopy at this age, you need to get your mammogram, you need to get your prostate, specific antigen testing done, and your blood pressure tests. People aren't always excited about each one of those, but it's just an understood thing that that's what you go and do, right? This is the age I go do this, and this is part of it.
Yeah,
But when somebody says, I'm going to do cognitive assessment, people go, oh,
yeah.
and or I don't want to do that. I really don't want to get my cognitive
And it's
assessment.
scary.
It's scary versus if this is just a standard of care. This is the age that you do it, and everybody has one, and it's your baseline data. That really that I think that word you used is so key to help resonate the reason, looking at it from the patient side, why it's so important to hopefully advocate and move for that with insurance companies and things to fund that and move that forward as a benchmark, a healthcare benchmark at a specific age. Really critical.
Yeah, and right now, people don't talk with their doctors about their brain health,
Mm-mm.
even when they're nervous, even when they're concerned. I mean, it's one of the reasons, imagine, I have to say, I do a lot with women. Imagine finding a lump in your breast and you tell your doctor, I'm worried about this. And the doctor says, let's give it a year and see what happens. What would you do? You
Yeah.
wouldn't wait a year, but that's what we do right now with brain health. So even when the patient gets up the guts to talk about their with their doctor and say, I'm concerned, a lot of times the doctor says, let's give it a year and see what happens. Because they're going to use the tincture of time for a diagnosis. But time is brain. And we know now that subjective cognitive complaints are actually a fairly good predictor for a future of mild cognitive impairment. So let's jump on that fast. Let's decrease the stigma. Let's not make people have to get the guts up to talk to their doctors about it. And let's start having brain health conversations, especially now that we know that over 40% of dementias can be prevented with lifestyle change. Let's talk about our brains. They're the most important parts of our body, and we never talk with our doctors about them.
Well, and I think another key thing is, you know, Alzheimer's is so prevalent in women, right? And one of the key things that I keep hearing right now, menopausal and women's health is all over the space as well. And the concept of brain fog that comes with menopause. My own doctor just asked me the day, are you experiencing brain fog with your symptoms? But
It's wonderful.
did they dig any deeper
Yay,
into
doctor.
did they dig any deeper into the answer? No, I was like, okay,
Yeah.
check for brain fog, or and so it's just kind of a given that this goes with aging with women's health, right? But I think we're missing that connectivity over, which is so many women are who are being diagnosed with Alzheimer's disease, and are we connecting those hormone connections and identifying that brain fog might also be cognitive decline? I think sometimes
There's a
missing
lot of
people.
gaps.
Yeah.
Yeah, there are a lot of gaps in our knowledge around sex and gender differences. I think for a long time, people thought the difference between Alzheimer's in women and men was just because women lived longer. And obviously, age is the greatest risk factor. But now they're finding that even when they account for age, um, more women are impacted as patients, as caregivers, and even as paid caregivers, right? When you think of CNAs and things like that. But there's also some nuances here, and that is how the disease manifests itself. Do you remember there used to be a day when we thought that women had the same symptoms as men in heart attacks,
Mhm.
right? And women weren't dying more of heart attacks because they didn't have that radiating pain down their shoulder. They had symptoms that looked different. And it was a real press to explain to the whole public in a public health way what symptoms were in women that were different than men. And women aren't just little men. And
No.
so But now we're finding the same thing with cognition. There are differences in the way that the female brain is structured. There's difference in things like verbal acuity and how the disease manifests itself and things like that. We really haven't explored that enough to be able to do the same thing with our brains that we've done with our hearts. And I don't think it's too much to ask that we should do that.
Outstanding. Critical point. So looking at a little bit more closer time frame, what are you excited to hear about in AAIC 2026 in London? What do you hope that was the things that you think are on the cusp of being released and that, cutting edge research that is it's coming through and it's coming out soon. What are you hoping we're going to be talking about next year at this time?
So I may cheat a little bit. There's another conference called the Clinical Trials for Alzheimer's Disease Conference, or CTAD, which happens in December. And
Okay.
I'm really excited for that conference because the semaglutide data is going to be released. And I
Oh,
think that is also going to be game changing. So that one is, I mean, I can't wait to see what happens there. And so I think that one's really exciting. I think at AAIC, the unique thing about AAIC and what's different about AAIC is that it's so much broader. Not only is it our largest conference, but it's broad. So there are tracks for everything. There's tracks for clinicians and for blood people and for proteomics people and for mice people and for in vitro people, like you name it, public health and advocacy. And so I'm really excited next year because I think we're going to see some results of some of these implementation studies. There's several organizations, including the Davos Alzheimer's Collaborative, which I work very closely with, who've been running implementation science studies to understand what are the barriers to why these clinically ready innovations, like digital cognitive assessments and blood tests, aren't getting used. And I'm really excited to see the results of those studies because I think it's a new discipline that we haven't had the blessing of being able to use because we didn't have clinically ready innovation until the last, 3 to 5 years. And so now we're going to put those innovations in health systems and we're going to look in a real world setting as to what are those barriers. And I'm really excited to see that because this field is a collaborative field, as I mentioned. We will rally together to sort out how to fix the problems, especially when we find barriers that are product agnostic. In healthcare system transformation, the data shows it takes 17 to 20 years for a new innovation to become standard of care.
wow.
This is a progressive neuropathological disease. We do not have 17 to 20 years to wait. So I'm excited to see the results of those implementation science studies and then be able to see the field grab a hold of some of those nuggets and go fix them. Because honestly, this field, the Alzheimer's community will do it. We'll work together and we'll solve those problems together. But we've got to have kind of that evidence basis to be able to go do it. And I think we should have that for AIC next year.
Outstanding. Well, I just want to thank you so much for taking the time to connect and sharing your experience at AAIC and your thoughts about the field and the community as a whole. And I have one final question for you, which is if somebody has an additional question for you,
Oh,
how can
sure.
they find you on LinkedIn or email? What's their preferred way for somebody to be able to reach out to you?
Yeah, LinkedIn is great. I'm on there a lot. It's at Phil Ferrell. And I'm also on X, but probably LinkedIn is easier to DM. And so that's a great place to find me. It's also a great place to follow along on some of these activities I like to do. I'm pretty active poster there so it's a good place to find whether there's challenges that I find out about or conferences, opportunities. So if you're trying to learn more about the space, follow me there.
Outstanding. Well, thank you again for connecting. I really appreciate it.
Thank you for having me.